Okay, so I think we should start now, and I think we'll have people joining us as we get into it. So welcome everyone to the Fatty Liver Foundation Wellness Webinar Series. This is the first in our series, a four-part series for 2021, which will be focused on wellness and the liver patient. We have a very interesting panel today. It's COVID-19 vaccination in people with liver disease. And so while our panels have traditionally focused on the more direct implications of liver disease on one's health, we're now looking at how other diseases affect and make more liver patients more vulnerable. And this is particularly topical at this time where we have the COVID-19 vaccination rollout. And there's a lot of questions around the uptake of these vaccines in patients with liver disease. So to that end, we have a wonderful set of panelists. Next slide, please. Okay, by way of introduction, I am the Chief Medical Officer of the Fatty Liver Foundation. I also have an academic appointment at the Department of International Health at Georgetown University. And currently I am based in Johannesburg. Here's another time zone for this global panel. Next slide, please. And this is something that we have now become, has become routine on our webinars, where we put forward our disclosures and our disclaimers. This is an education panel. It's to discuss what the current state of research is. We talk about it in broad terms and specific terms, not in the context of any particular person's clinical condition. So it's very important, even though you may ask questions about yourself or someone that you know, it's always best to confer with your health team, your hepatologist, your primary care physicians, etc. Next slide, please. Okay, so our expert panel, we have Wayne Eskridge. He's our co-founder and CEO of the Fatty Liver Foundation. We also like to think of him as our patient advocate in chief. And so Wayne has been flying the flag of patient advocacy for a long time, and he will relate perspectives, particularly from the patient community. We have Professor Ellie Barnes, who's the Professor of Hepatology and Experimental Medicine at the Nuffield Department of Medicine at University of Oxford. And then we have Dr. Andrew Moon, who's a fellow in the Division of Gastroenterology and Hepatology at the University of North Carolina School of Medicine. So it's an exciting panel, and they have tremendous experience in many areas of immunology and the use of vaccines in patients with liver disease. Next slide, please. Okay, so with that, we will go to Professor Barnes. And Ellie, please tell us about the work that you've been doing and some of the observations and findings that you've been having along the way, and how this is relevant to patients with liver disease.
Yeah, okay, thank you very much. So I'm at Oxford, as you said, in the UK, where we've got a terrible pandemic at the moment, as most people will have heard, with particular variants, circulating here that are of particular concern at the moment. I've been working with Andrew now since the start of the pandemic. Andrew, I think since March, April last year, where we established on the same day 2 different registries, one from Oxford called COVID Hep, and Andrew launched Secure Cirrhosis on the same day. And so rather than kind of compete with each other in any way, we thought it'd be much better for the patient community and everybody if we got together and joined forces. And so we've been working very closely over the last kind of 10 months to try to understand the outcomes of COVID infection in patients who have got underlying liver disease, including the transplant patient population, and patients with fatty liver disease, alcohol, hepatitis. And there's been quite a lot of outputs from that piece of work over the last 10 months. And I'm also very involved with vaccine immunology. because over the last really eight years, I've been trying to develop a vaccine against hepatitis C virus infection using chimpanzee adenoviral vectors, which is very like the Oxford AstraZeneca vaccine that's now been licensed for SARS. And I'm working on vaccines using the adenoviral vector platform for hepatitis B therapeutics as well. And have got a large program at Oxford looking at the immune response to people who are naturally infected with SARS-CoV-2, mostly the healthcare workers, with a particular interest in kind of T-cell immunology. You know, and maybe we'll get into some of the specifics of the immune response later on. So that's my background, and I'm very much kind of looking forward to hearing, you know, questions from the patient population. Really, I think yours are the questions that really matter, and we'll try to answer those today.
Excellent. Thank you so much, Ellie. Andrew, over to you. Tell us about some of your work and what you've been doing in this field.
Yeah, thank you very much. So I'm a current transplant hepatology fellow at the University of North Carolina. My primary clinical and research focuses were primarily on the diagnosis and treatment of liver cancer. And then as the pandemic came about more recently, I've been focusing on COVID-19 and liver disease. As Ellie had mentioned, I'm the creator and co-principal investigator of Secure Cirrhosis, which is an international registry that has collaborated and worked very closely with the investigators from Oxford, including Dr. Barnes, and they've run the COVID-HEP registry. So these two registries have collected data on patients with chronic liver disease, including fatty liver, cirrhosis, prior liver transplant, who have developed COVID-19. And we've really been able to collect data on the baseline characteristics of patients and the complications and death related from COVID-19. And this has been able to inform us on potential risk factors of poor outcomes from COVID-19. Moving forward, our registry is going to continue to collect data. And one of the things we'll be assessing is post-vaccination COVID-19 infections. As I'm sure we'll discuss today, it's going to be really important. While we have a lot of data already showing that these vaccines are very safe and effective, it's going to be really important to continue to collect data. And one of the things we want to look at is the potential for infection after the vaccine. To date, we've already had a lot of really important findings, and some of our findings have informed the potential risk of COVID-19 in patients with liver disease. And I think this kind of plays into the benefits and risks discussion with the vaccines. We found that cirrhosis, and particularly decompensated cirrhosis, are major risk factors for COVID-related death. And there's really been a stepwise increase in morbidity and mortality from COVID-19 as liver disease progresses. So I'd be happy to kind of expand upon that as we field questions. But if you're interested in learning more, you can go to the Twitter pages of Secure Cirrhosis or COVID-HEP, or at covidhep.net or securecirrhosis.org.
Excellent. I have a couple of follow-up questions, but before we get to that, Wayne, from the patient community perspective and the Fatty Liver Foundation, would you like to make a few overarching comments?
Indeed. As most of you probably know, I am a cirrhosis patient and founder of the Fatty Liver Foundation. So I'm really interested in this vaccine question. And as the foundation, we get a steady flow of questions and concerns, and we have an opportunity to have a very good sense, I think, of what the community is fearing and feeling and the things that are important. So as we thought about getting this this panel together, one of the things that I'm so pleased by is that Ellie and Andrew are where they are as to what they do, because we have a lot of people that you typically see who are basically treating primarily. They are either kind of talking heads, if you will, or they are primarily engaged at the final treatment and transplant and those kind of levels. And I really, really wanted to have some expertise from the foundation of these vaccines, how these are developed, you know, so we could have a sense more of, you know, these didn't just appear suddenly out of the blue. This has taken endless amounts of work by a lot of people. And, you know, Ellie and Andrew have been involved in that, and Andrew kind of bridges the chasm there from the treatment side, you know, and the research side. So I think this is an extraordinary panel for our patient community to have a chance to engage with.
Excellent, thank you, Wayne. Gabriella, any more slides that we have to go through? I think just the last thing is the disclosures of our panelists, so everyone is aware of that. And with that, before we get into further questions, we have a poll for all our participants to take. So there's no any conflicts of interest or disclosures from our panelists, and the Fatty Liver Foundation receives various forms of streams of funding, but we do maintain independence with the content of our work. So let's pull up the poll, and all the participants can take it. So if you were offered a COVID-19 vaccine, would you take it? Yes, no, or unsure?
Are we voting, Neeraj?
Absolutely. It may skew the numbers, but I think we're part of the general public. Okay, are we going to show the poll results now, or we'll wait for the end?
We'll wait for the end because no one has voted yet. Yes.
Okay, so so I want to dive into the vaccines and the uptake of the vaccines and some of the thinking that we've gotten from our community. Before we get to the rollout, I want to go back to this question of risk, the risk of the liver community. Now, what's interesting with fatty liver disease, NASH, and many of these patients who progress to fibrosis and cirrhosis is that there's usually some sort of comorbidity. And the comorbidities that have been listed in the phase 1 of the vaccine prioritization in the United States are the big ones that we know of: diabetes, liver disease, obesity, metabolic syndrome, etc. But there is a clear omission of patients with liver disease. And so from your perspective, when we talk about there being a higher risk of cirrhosis patients or patients with liver disease, is it a sum of the comorbidities, or is there a new level of risk for liver patients that include the risk that they have from the comorbidities that result in their liver disease, and then some more? So I'd love to get your perspectives on that.
Yeah, so that's a really good question. And so with this, with the registry and the resulting research studies that we conducted, we really wanted to try to isolate each of those risk factors. So we wanted to say, you know, even if you controlled for all those other comorbidities and as well as age, gender, et cetera, is liver disease a risk factor for complications from COVID-19 and mortality from COVID-19? And what we found is that even after you adjust for those comorbidities, patients with cirrhosis, and particularly decompensated cirrhosis, so patients who have had ascites, variceal bleed, have hepatic encephalopathy, are at much higher risk of COVID-related mortality. Now, regarding risks from specific etiologies, this is obviously the Fatty Liver Foundation, and individuals who don't have cirrhosis may be interested. Is fatty liver a risk factor? What we found is that even when adjusting for all these comorbidities in the presence of cirrhosis, alcohol-related liver disease increases the risk of mortality from COVID. Fatty liver was not found to be a significant risk factor, but I think an important caveat to this is that many of the patients who have fatty liver disease have one or more of the risk factors that we know increase the risk of morbidity and mortality from COVID-19. So even though non-alcoholic fatty liver disease was not found to be an independent risk factor in our study, patients who have obesity, diabetes, who are older, are still going to be at higher risk of COVID-19 morbidity and mortality.
Ellie, some perspectives from your side?
Yeah, I mean, it's interesting, the difference in the vaccine priority strategies, if you like, in the USA compared to the UK, where, you know, here it's completely age focused, really, to start with. So at the moment, we just started vaccinating the over 85s, and we progressed down to the now we've just reached the 70 to 75-year-old age group, and we vaccinated those people with medical conditions where they'd been advised to shield completely by the government. So patients who've got kind of leukemia, the really, really sick people. And actually vaccine, you know, people that just have comorbidity haven't been prioritized here for vaccines in any way, including patients with liver disease. And as Andrew just said, we've got very clear evidence that particularly people with advanced liver disease, so once you've got liver cirrhosis, your kind of risk of a bad outcome from infection goes up, and as you get more progressive liver disease, irrespective, I think, of the etiology, your risk goes up further. And the other interesting and important thing that we found is the thing that patients get sick from is actually kind of respiratory disease mostly. I mean, there is some decompensation of liver disease too, but the thing that really kind of gets people is actually kind of COVID in the lungs, even though your primary disease is kind of in the liver, which is interesting.
Absolutely. So I think there's something interesting in the patterns of prioritization, age related, and then the comorbidities, right? Two very advanced scientific nations, one should say. One would have hoped there was convergence. But is there an element of clustering when it actually comes to this prioritization? And so, for example, in the UK, based on age, if in a household there was an 85-year-old and a 75-year-old, would they be vaccinated together? And similarly, if someone had liver disease and diabetes, would they be caught under diabetes or metabolic syndrome or cardiovascular disease, which was another prioritization? So did we cluster or group these sort of prioritizations in that sort of way?
Yeah. So both my parents-in-laws are very good examples, because my parents-in-law are 80, 85 and 75. And they've been vaccinated entirely different times. There's no clustering at all by age. It's really strict here. It's completely by age limit, and it doesn't matter who you live with. And I think that's probably right, because it's, you know, it's a very political issue, making the rollout of these vaccines as fair as it can possibly be. there's also no clustering here by disease etiology, within households. It's every man and woman for themselves, independently assessed for risk and vaccination. Is it the same there?
Andrew?
It's true in the United States. Yeah, we kind of consider the individual risk factors, and age over 75 and now 65 are being prioritized, followed by healthcare workers. And then it goes to individuals with high-risk comorbidities thereafter. But there's no real consideration of clustering within a household.
Wayne, I want to turn to you. When you first saw the guidelines in the United States and that the phase 1 rollout did not include liver patients, what was your reaction, your feelings, and what did you want to do about it?
Oh, that was very frustrating. I study this, live it, and I couldn't believe that with all of the problems that go along with NASH and the comorbidities that NASH is associated with, that liver disease really didn't show up on the list. So we complained, but you reach out to the government and it's kind of a black hole. But we officially objected to that from the foundation's perspective, and we understand the difference between looking at NAFLD and NASH, as disease processes, but we just felt that there wasn't any consideration. And as I thought about it a little bit, the reason is that in the US, we don't diagnose those liver diseases. So people coming in with COVID may or may not have had liver disease. If it wasn't pre-diagnosed, the hospital wasn't taking time to figure out, okay, well, do they have it or not? They're treating their acute symptoms at the time. So I think because of our policies, our data is skewed. And I really think that led to what I think is an unfair weighting of how liver disease is judged in this COVID epidemic. I'm a complainer of one here, but that's my view.
Well, and our sort of comfort, I want to say, is that we were hoping that most of the liver community would be included through other comorbidities that they may have had or may have, and we haven't sort of studied that overlap or if there's an excluded subset in that cohort. So switching gears now, we are in the process of rollout globally, and every day we're hearing about the vaccine supply chain getting stronger, production is increasing, and I fear at times we can't distribute it fast enough in that regard. But hopefully these are teething problems and we'll get smoother with it. So with that being said, I want you to sort of answer this particularly from two angles. One is safety and the other is efficacy of the vaccine, right? Because this is at the forefront of everyone's mind. Is it safe? I mean, going to get some sort of reaction, et cetera, notwithstanding some really far out conspiracy theories about the vaccine. But from a scientific point of view, safety and then efficacy, does it work? And I want you to sort of answer that in the context of liver disease, but various stages of liver disease. Okay, so people who have comorbidities with early NAFLD, and then those with NASH and fibrosis and cirrhosis. What is the safety and efficacy profile on vaccines from the research that you've done?
Yeah, so what we know from the vaccine trials of existing vaccines is that they look incredibly safe. The most common vaccine side effects are arm pain, fatigue, headache, low-grade fever, chills. These are similar side effects to what you'd expect from other vaccines. And they're actually, when individuals get these side effects, they're a good sign that the immune system is doing what it's supposed to do, which is to identify the spike protein in the setting of an mRNA vaccine and building up an immune response against the virus that causes COVID-19. Those minor side effects are usually gone 1 to 2 days after the vaccine dose is given. Of course, the concern is always going to be not about those minor side effects, but the more severe adverse effects, some of which have gotten some play in the media. Those side effects, the severe adverse effects, were incredibly rare in the vaccine trial, seen in similar rates in the vaccinated group and the placebo groups. So I can talk about one of the vaccines that has been approved for emergency use in the United States, which is the Pfizer vaccine. Serious adverse events were reported in 6 out of 1,000 individuals who got the vaccine. In comparison, severe adverse effects were reported in 5 out of 1,000 individuals who got the placebo shot. So that means that many of the reported adverse events were probably not due to the vaccine itself, and the rates were very similar in the two groups. Regarding the risk of side effects or adverse effects in the liver disease, patients with underlying liver disease, we don't have a lot of data to tell us for sure, but there is no reason to anticipate that the risks of COVID-19 vaccine would be any higher for patients with fatty liver disease or cirrhosis.
Ellie, do you have anything to add to that?
Yeah, I mean, I guess I could just kind of outline the numbers of people with kind of significant comorbidities that were included in the large phase 3 kind of trials. And there's really two kinds of vaccines at the moment that are forging ahead globally. One are the RNA vaccines, and the other are adenoviral vectored vaccines. I mean, for the RNA vaccines, those are Pfizer kind of developed out to Germany and Moderna in the USA. The large trials of how effective those vaccines were for the mRNA vaccines, that's Pfizer and Moderna, included thousands of people, so kind of 8,000 people plus. But a tiny proportion were known to have liver disease in those studies. So only 214 out of 8,000 for the Pfizer vaccine. So the number of patients with liver disease was definitely small, and the same for the adenoviral vectored vaccine trials. But having said that, what we know about the biology of those vaccines and how they work, I think it's almost 100% certain that those vaccines, because of the mechanism of action, will be safe in patients who have got liver disease. They're not live vaccines. That's the important point, really. These are not vaccines made from pathogens or bugs that can kind of replicate. They're completely inactivated so that they can't possibly cause infection. So even in someone who's got a compromised immune system, those two types of vaccines, both the adenoviral vectored vaccines and the mRNA vaccines, kind of biologically should be completely safe. There isn't any plausible reason why you'd have more side effects in a liver patient, I think, compared to somebody who doesn't have liver disease. That's not to say they are going to work as effectively. And I think that's not to get confused between those 2 points. There's the issue of whether they're safe, and then there's the issue of whether they're effective. And I think we can be pretty confident they'll be safe. And I think we don't currently know if they'll be effective. That's my view on the position at the moment.
That's one of the things that I get asked quite a bit is when I'm talking to people that take a lot of steroids, for example, that are immune compromised as a result of their disease, and they're cautioned, to be so careful about not contracting anything or exposing themselves, and so they're really concerned about whether or not this is a good step for them. And would that group, specifically people that are on steroid treatments, would they have a reason to be concerned?
I think there's no reason to be concerned about safety, and they should take the vaccine. But they should have 2 doses of the vaccine for sure, because 2 doses in terms of the immune response is clearly better than 1, that from all the published data. So they should definitely have the vaccine, and then we urgently need some studies where we look at the immune response to these vaccines in people that are on various drug combinations, steroids and other immunosuppressive agents, and we need some proper studies where we understand the immune response to the vaccines in people with different stages of liver disease. And those will come in the next 6 months. They'll come very, very quickly, but I don't see a downside if you're a patient to having those vaccines when they're offered, because some protection will for sure be better than no protection. And even moderate amounts of protection may prevent you from kind of getting severe disease should you get infected. So even low levels, relatively low levels of antibodies or T cells generated from these vaccines are likely to, I think, are likely to prevent you from being hospitalized, or worse from COVID. So have the vaccine, but we need studies to see how effective they really are.
I think that's such good advice. That the community is struggling with it. There are a lot of people that are uncertain about taking the vaccine, and particularly when we are contacted by people of color. The ethnic communities are especially concerned about the vaccine. So I get a lot of questions with the combinations of those, and I'm really pleased to hear you say that, because my counsel is, get the vaccine. You really, really don't want to get the disease with this kind of a physical condition.
I'd echo all those points. I totally agree. There should be no safety concerns with patients with underlying chronic liver disease or fatty liver. As Ellie had pointed out, we know from prior vaccines that the immune response in patients who are immunosuppressed, including those on steroids or who have advanced liver disease, is not as robust when getting vaccines for hepatitis A, B, influenza. But it's important to point out with the COVID-19 vaccine that in the trial populations, it worked incredibly well. So these vaccines, for instance, the Pfizer and Moderna vaccines that are approved in the United States were 95% effective at preventing symptomatic COVID infections. They're nearly 100% effective at preventing hospitalization from COVID. The maximal benefit is going to be after the second dose. So even if you are on steroids, even if you do have advanced liver disease, even if you've had a prior liver transplant. I think it's still worthwhile to take these vaccines. One, because we don't have any safety concerns in these populations. And two, even though vaccine may be a little less effective, the starting bar is pretty high. So a little less effective than 95% is still very, very effective.
Yeah.
So just to reiterate, there's nothing in the vaccine that can cause illness. There's no live virus, there's no attenuated virus or anything like that. And also importantly, something that has come up in many vaccine discussions is not the vaccine itself, but the fillers or what goes into the vaccine process, making process. So there's nothing that has actually shown toxicity in what's in the medium of the vaccine components in this regard. So the second point, if we have liver patients, and some of the data suggests that the seroconversion or the immunological reaction they have in response to the vaccine may not be as high, is there anything they can do to confirm whether they have the vaccine has inferred immunity on them? I know with hepatitis B and hepatitis B particularly, after the vaccine, you could check if you had antibodies, whether there was inferred immunity. So is there something that the liver patient or the liver community can do?
Currently, and this is more Ellie's expertise, so she can probably add to this. Currently, it is not recommended that individuals check antibody response to make sure that they have immunity to the vaccine. And that goes for checking for antibodies before you receive the vaccine. So there are many commercially available antibody tests, and you know, they're not particularly accurate at identifying if you truly have immunity to the coronavirus. So I think I would not recommend checking before the vaccine to see if you need to get it, or checking after the vaccine to confirm that you have protection against the coronavirus. Now, this is, and Ellie, feel free to chip in, but I know this is going to be a evolving field very quickly, and hopefully we will have ways to assess for immunity in the near future.
Yeah, I think it's a complicated area. So a bit like hepatitis B, you can measure antibodies generated by the vaccine, and you can quantitate those. So you can measure those. There's a number of problems though, and the problems really are, at the moment, there's about 60 commercial companies and kind of additional kind of academic tests that allow you to measure those. So, you know, the tests themselves are not standardized, which is a problem. And the other issue is we don't know what level you need anyway to protect you from future infection. So I think those are the two reasons at the moment why the advice is there's no point measuring your response after vaccination, because we don't know what that response really means, because there's lots of different ways of kind of measuring it, and because we know from these very big studies that nearly everyone is protected anyway. So those are the reasons not to measure it. My own view is that this may well not be true of people who are on immunosuppressive drugs or people who've got advanced liver disease, ultimately, once we've done some more kind of research on this, because it may be that subsets of patients don't make an immune response really at all to the vaccine. That would be very easy to quantify. Even now, you could measure antibodies, and you could measure. So there's actually two parts to the immune system. There's the antibodies, which we think are the things that mostly protect the virus from getting into cells that the vaccine makes. And then there's T cells that provide help to the antibody generation. And these vaccines generate really high levels of T cells and antibodies. And the issue really is that different drugs and different diseases may impact differently on antibodies and T cells in particular are really more complicated to measure. So this is quite a complicated area, but I think in the future, we will move to a world where in people who've got disease who are on immune suppressive drugs, we may end up 6 months, 12 months from now measuring immune responses to these vaccines, but probably never in people who are healthy, otherwise healthy. I think there people will just be vaccinated. So I hope that's helpful. I think it's complicated.
Well, I mean, but that's, I think, a good sort of vision statement that for those people or those communities that are at risk for not getting the immune reaction, we may be able to develop tests to confirm that in the future. So that's promising, and I think it gives the patient community much more confidence in knowing. And I want to get back to this point of confidence. I think you guys have said beautifully and firmly that, you know, this is safe and it is effective. But how do we build confidence in, well, one, communities that have previously been experimented on, that have total mistrust of the medical world, but also as a liver community that has been sort of a very marginal field in mainstream medicine, that hasn't built too much trust or confidence in many of the medical interventions. We don't have a therapeutic for NASH or NAFLD at the moment, a medical therapeutic. So how do we build confidence in this, that they will be taken care of and that the vaccine is safe? And you know, please draw on examples from your country context, local context, on what is being done to build that confidence.
Yeah, I mean, I'd be interested to hear what kind of Wayne and the patient community thinks about how we should build confidence.
You know, it's something that we struggle with all the time, because it's just such a common question that comes in through our peer groups and through our support organizations, because that discomfort is very real. And unfortunately, we have an element in our society and in our news business maybe that is fanning the flames of that. I mean, we have people that are actively promoting the idea that there's a deliberate dysfunction in our system, and I don't believe that's the case, and I don't know how to counter that. I don't find in the information that comes to me any persuasive examples of people saying, you know, I had this happen, and this is an example of what I'm complaining about. They're all second and third and 20th hand kind of, you know, I heard this from Uncle Joe's barber kind of thing. But, you know, it's corrosive, and it is just so frustrating because, you know, we work really hard on the issues of population sensitivity. You know, for example, it's a really big deal for us that the Latino community has such a high liver cancer rate. You know, we focus on those kind of things, and you know, there's no question that there's a real interest in population health. So this business, this undercurrent of distrust, I just am beside myself as to how to respond to it. I
mean, I think there's there's vaccine mistrust, which I think involves sympathetic, explanation really to patient groups and population groups as to why we think these vaccines are safe and why they're effective and why they're important, and all the amazing good that vaccines have done in our society over decades. I mean, the amount of pain and suffering that vaccines prevent currently is absolutely enormous. And the problem is that's not visible because those diseases don't happen because we have these vaccines and people are vaccinated.
Yeah, you don't have the disasters to point to and say, see, you can avoid that.
We did have disasters in the UK when, for example, Andrew Wakefield, who actually was my boss at the Royal Free Hospital in London, moved to the States now, where he's doing very well, I think. But he kind of promoted huge mistrust in the measles vaccine, and there were large parts of the UK that weren't vaccinated with horrible outbreaks that we had here for the first time. So a single person is able to generate large amounts of disease through kind of spreading this kind of stuff in our communities, without the upside of seeing all the awful conditions that vaccines prevent, like polio. I mean, we just, when do you ever see polio now? Awful disease, and it's just not there. So I mean, there's the upsides of vaccination are kind of hidden, whereas any tiny possible side effect is kind of pushed in the news very hard. It's the imbalance in all of that is enormous. And then when you see the teams of I kind of I'm exposed to the teams of people that have been working to develop the Oxford vaccine, the Oxford AstraZeneca vaccine. Those people haven't had a day off, pretty much a day off over the whole of last year, including weekends. They've been going like 7 days a week, hours a day. People of all kind of, seniorities, from the people that are the kind of runners to the people that are kind of pipetting to the people in charge. The personal investment of people to make these vaccines available to save lives is absolutely enormous, and I just wish that was more visible too. And it's really altruistic. There's no other incentive for these people other than to try and do some good in the world, in my view.
And as a public health person, I think we come with a rational message and evidence-based, and a lot of people don't act on rational messaging. There's emotive responses and latching on to types of things, which comes to the other part of the question I want to ask, which is, the house is on fire and we're trying to respond to, well, liver patients in this time of crisis. How do we involve patients at the development phase? How do we change the baseline for this community so that we reduce their risk, we get them more engaged? That will result in an increase of vaccine uptake or any other intervention that we may have down the line in response to something. And so instead of sort of looking now, what do we do with this rollout and this acute crisis? How do we change the baseline for liver patients when it comes to vaccine access, efficacy, involvement in trials, etc.?
Yeah, so I think in general, kind of COVID aside, in general, when it comes to vaccine development, drug development, the patient needs to really play a key role in identifying, what, in the case of non-alcoholic fatty liver disease, what about the disease itself affects their life? What do they want fixed? What do they want addressed? And I think I've seen more and more of that as far as getting patient advocates involved, getting their buy-in, and trying to incorporate all their feedback into designing trials, rolling out medicines, and in this case, rolling out vaccines. Because I don't think we as medical professionals are going to be effective unless we have a very good understanding, buy-in, and good feedback from the patient community.
Mm-hmm. Ellie, do you have anything to add to that?
No, I just think strong patient advocacy is kind of crucial at this stage. I think during a pandemic it's been difficult. Things have gone at such speed that decisions have been made very fast. That in the context of a pandemic, it would be very difficult, I think, to in those first months to bring patients into the fold of the whole thing. But we're at a point now where that's, where things are different. I mean, the house is kind of burning, but we know what the fire looks like now, I suppose I'd say. And so we can kind of manage that now. And I think we can, we just need patients who believe in this, helping, working with us, I think, to spread the word. And I mean, this kind of forum is a good start where at least we're having discussions about it, and some the right messages can be disseminated. Yeah, I mean, Wayne may have some good views on this again.
Well, I really do. It is encouraging because we are hearing the right kinds of words. There's a lot of support conceptually for bringing the patient more into the process. But there's not that many people who are prepared really to fund the outreach and to really provide the ability to create the tools and mechanisms to recruit that kind of participation. We feel like it's coming more as time goes on, but so far the action on the ground doesn't really match the goal, the rhetoric, but it's very encouraging that everybody is wanting to talk about it and think about it that way.
Well, in the spirit of amplifying the patient voice, I'm going to invite people on the participant list to raise their hand for a question, and I'll call on you. In the meantime, I want to convey a message that came through, and this is a very important communication tool, which is peer advocacy among patients. And so we have, I'm going to use her initial J, who says, I am 65 and have advanced compensated cirrhosis and NASH and took first Pfizer vaccine with no problems. And I think hearing that from patients and that sort of network is something that reinforces the message really well. Our first question is from Jane Johnson. Gabriella, can we unmute Jane to ask her question?
Yeah, I've just asked her to unmute.
Okay.
Okay, can you hear me?
Yeah, we can hear you, Jane.
So I live in kind of an odd situation where I live under the care of a research hepatologist, and I basically have ad hoc access to FibroScans every 6 months regularly or whenever I want to call for them. So last summer I had the shingles vaccine, the measles vaccine, and the flu vaccine in rapid fire succession. And 3 weeks later, I had a FibroScan with absolutely no impact to it. So my question is, why would this be different?
When you say you had no, sorry, Jane, when you say you had no impact to it, you mean you had those vaccines and your FibroScan score didn't change?
Exactly. So is there any reason to assume that this would be any different than, and the shingles vaccine was horrible, but it had no effect from a liver perspective?
Yeah, so I think that's a good question. So the FibroScan machine, which I'm sure you know, but for everybody else, it's a good way of measuring liver stiffness. And liver stiffness is correlated with liver-related risk of decompensation events and liver cancer and liver-related death. So the underlying liver disease, whether it be hepatitis C, hepatitis B, NASH, if it goes unchecked, it can lead to increased scarring in the liver, which will increase the FibroScan level and may increase your risk of those complications. One of the complications of liver disease is that the immune system doesn't work quite as well, which is why we very strongly recommend that you get vaccines to shingles, the Pneumovax vaccine, hepatitis A and B. While those vaccines are recommended to reduce your risk of contracting those diseases and getting complications from those diseases, the vaccines themselves should not have any effect on the amount of scarring in the liver and the liver fibrosis scan. So I wouldn't expect that the COVID-19 vaccine would have any effect on your FibroScan results. But I think that it would be recommended because it would reduce the risk of acquiring COVID-19 and getting complications or death from COVID-19.
So to that point, another question that has come in, the FibroScan is one way of assessing sort of the liver health and liver function, but we also have our other markers, platelets, ALT, AST, protein, albumin, etc. Should a patient with liver disease monitor those before or after vaccines? And should that tell anything about what they do in taking vaccines?
Yeah, so this is along a similar theme. So the platelet count can be a marker of the amount of portal hypertension. So the portal vein is a large vein that goes into the liver. As more scarring develops in the liver, the pressures in that portal vein will increase and your platelet count can go low. And so low platelet count can be a marker of portal hypertension and more advanced liver disease. So I think that patient population, because the risk of COVID-19 is so high in that patient population, as has been shown with our registries, I think it'd be very important for individuals with liver disease and low platelet counts to get the COVID-19 vaccine. I'm not aware of any data that suggests that the COVID-19 vaccine would have any effect on the platelet count or the amount of portal hypertension. So I don't necessarily think that monitoring the platelet count before and after the vaccine would be recommended.
Okay, excellent. Ellie, anything to add to that?
No, I mean, I could just add that just an important principle: when you inject these vaccines into the arm, the vaccine particles don't go to the liver. They go into the muscle in the arm, and they induce an immune response in the lymph nodes that drain the arm. So I mean, I think people picture these particles as kind of going all around the body and getting into the liver. That's not what happens. So I think if you picture this as a local event that's happening in the arm, kind of generating an immune response, and then it's those really effective immune cells that protect you from infection that go around the body. I think picturing it like that is kind of reassuring, probably. And I'd agree with Andrew completely. I think if you've got if you've got low platelets, any sign of portal hypertension, you should have this vaccine, because the risks from catching COVID are so much greater than these vaccines, as we've talked about.
That's excellent, and I just want to let our participants know that that we have a range of questions, and we want to, and people are at different levels of understanding of the issue, and we want to sort of clarify as many things as possible. So 2 other questions that have come in. If someone has a history of allergies and even had previous anaphylactic reactions, is there any risk of getting any type of exacerbated reaction to the vaccine? They haven't stipulated what their allergies are or what their previous anaphylaxis was to.
Yeah, so this is a question that's come up with my patients quite a bit. The risk of anaphylaxis has gotten quite a bit of attention in the media. The current estimates are that in the general population, the risk of a severe allergic reaction is really low. So it's estimated to be about 1 out of every 100,000 individuals who get anaphylaxis, and it may even be lower than that. Those individuals who did get the anaphylactic reaction in the trials were people who had a history of significant allergies. Many of them were already carrying an EpiPen when they got the anaphylactic reaction, but it's still really, really rare for individuals with a history of allergies to develop anaphylaxis. So during this time that they were monitoring for these events in, I believe it was the Moderna vaccine, there are only 17 cases reported in individuals with allergic reactions. Most of these reactions occur in the first 15 minutes or so after getting the vaccine. And so it's a protocol at most vaccine distribution centers that patients be monitored for a minimum of 15 minutes. If you have a history of allergies, you're generally monitored for 30 minutes. There are medical professionals there, as anybody who has experienced anaphylaxis knows, there are very, very effective treatments if an anaphylactic reaction does occur. And so as long as you're properly monitored after the vaccine is given, there are ways to prevent against any complications from that anaphylaxis. So the only absolute contraindication, so the only reason you shouldn't get the COVID vaccine is if you have a prior severe allergic reaction to any component of the COVID-19 vaccine during your initial dose. So if you develop a reaction to the COVID-19 vaccine itself, it's recommended that you see an allergist before you get the second vaccine. Of note, for the people who have allergic reactions to other things, none of these vaccines contain eggs, gelatin, latex, preservatives, and there should be no concern in individuals who have had allergies to insect venom, milk, eggs, animal dander, or oral medications like antibiotics. So that's a common question I get. I've had a reaction to Bactrim or a sulfa in the past. Should I get the vaccine? There should be no concern. And so overall risk is very low. Prior allergic reaction, you may be at slightly higher risk, but as long as you're monitored correctly, these vaccines are still very, very, very safe.
Excellent. I think, yeah.
I could just briefly add to that, you know, anaphylaxis, as Andrew said, is incredibly rare with the RNA vaccines, and it's not reported at all with the adenoviral vectored vaccines. It's just, you know, not a side effect. So, you know, with the adenoviral vaccines, no one is monitored at all after the vaccination. It's literally an injection and the patient goes away. Even for the Pfizer vaccine in the UK, we're no longer monitoring afterwards because these events are so incredibly rare.
So those were excellent responses, and I think they touched on many, many questions. I want to be cognizant and respectful of everyone's time. So I'm going to open up for closing comments from our 3 panelists. But I have sort of made a few summary notes, and we will put out a document with summary points from this call. I think this we can distribute widely to various patient groups and general public audiences. So one, the vaccine is safe, period. Okay. The vaccine is effective. Okay. Evidence-based education, awareness, and we've been evangelical about spreading the word of expanding access and uptake of the vaccine through the Fatty Liver Foundation. I think it was very important that NAFLD patients or fatty liver disease patients may not be at additional risk for fatty liver itself, but certainly from the comorbidities, whereas more advanced liver disease like cirrhosis does have its own higher risk associated with this. So those are some of the key things that we looked at. And then the patient voice is a key role in spreading the message and getting that peer advocacy. So with that, I'm going to turn to Ellie first for a few closing comments, and then Andrew, and then Wayne.
Yeah, thank you. I've got nothing to add really. Just to be very clear that the increased risk that you just described, Neeraj, with increasing cirrhosis is with infection, not from vaccination. In my mind, that the risk from infection is massively higher than any possible risk from vaccination, and all liver patients should be vaccinated. If you're asked as a patient to participate in a study where we're measuring vaccine efficacy, then please do participate, because I think this is an important area for us to evaluate over the next 6 months.
Excellent.
Yeah, I'd echo everything that's been said. I think we've learned a ton about COVID-19, particularly in patients with liver disease. We know that patients with liver disease, and particularly cirrhosis and decompensated cirrhosis, have particularly bad outcomes from COVID-19. We know that these vaccines are incredibly safe. We know that the vaccines are incredibly effective. And we know enough about the safety of other vaccines in patients with cirrhosis that I am strongly recommending to all my patients, and I would recommend to any family members with fatty liver or cirrhosis to get the vaccine as soon as it becomes available.
Excellent. Wayne, over to you. And please do touch on some of the trial recruitment strategies we've been thinking about at the Fatty Liver Foundation as well.
Well, thanks, Neeraj. I really appreciate the panel, because this has been an excellent discussion. We could easily spend 2 or 3 more hours. A couple of things that I might add. This is very safe, and as a patient, as you get this vaccine, don't assume that immediately afterward that you're safe. I mean, you've got to give the vaccine time to do its magic trick. And so you've got to stay safe for a couple of weeks after even the second booster would be my advice. And particularly the more serious your liver disease, it's really important to not start to think that you're suddenly Superman. The value of paying attention to this, for those of you who have joined because you were uncertain about whether you wanted to take the vaccine, and I continue to be surprised at the number of people that say in the forums that they're reluctant to do it. I hope that this has answered some of your questions, and I hope that you'll carry that message out to your peers, because it's really the best communication we have is patient to patient. And these are among the most knowledgeable people about this vaccine that we could find. And so I hope that you take that to heart. We're working as a foundation to develop additional programming and testing programs. We have, as our next event on March 10th, we'll be doing a program on non-invasive screening. So we'll notify you, but put that on your calendars. You know, that this is another subject that's near and dear to our hearts, because identifying the disease and being able to monitor it is really an important part of wellness for us as a patient population. But I'd really like to thank Andrew and Ellie for their participation here today, and I think this has been a really good discussion, and I appreciate being a part of it and having you join us.
Excellent, and the the transmission of these messages is going to go way beyond this live webinar. We'll have a recording of this and we'll distribute it, and also have flyers that come out of this. I want everyone to pay attention to the poll now. We're going to do an exit poll and see if we've sort of moved the needle on people taking the vaccine. I will reveal the results shortly. So Gabriella, can you pull up the poll, please? Okay, so from the first poll, 83% said yes, they would take the vaccine, and 17% were unsure. A certainly well-informed group here that no one would refuse the vaccine. Okay, and are we doing the poll again? Have we pulled it up? Oh, there we go. Poll is up. Okay, and let's see what results we have now. And we are radical incrementalists here, so any shift in the right direction, we'll take it.
Technology will drive you crazy.
Yeah. Has it come up?
I can't see it, but Henry might be able to see those poll results for us.
Henry, do you want to just tell us if it can't come up? Or can you put it up?
Oh, he's shared them with me in just a second.
Okay.
It seems we have made some progress.
Okay, 100%. We should do these more often. Well, please, everyone, join me in thanking our wonderful panelists. Thank you for sharing this information. And I know it was quite complex, but you made it so accessible for our participants. And we really appreciate you joining us today. So thank you so much. And everyone, be safe.